Hello, we're talking about kidney function, anatomy and physiology of the kidneys. This is from chapter 25 of the Marieb Human Anatomy and Physiology textbook. And in our previous session, we were talking about how the kidneys can concentrate or dilute the urine to accommodate the needs of the body, to get rid of excess water volume or to retain water in times of dehydration and so forth. And today we're going to pick up on that process, talking about drugs that can manage production of urine called diuretics. Diuretics are chemicals that increase urine production or increase urine output, and some things that are familiar perhaps that cause increased urine output, such as ethanol, work by inhibiting antidiuretic hormone. ADH inhibitors will cause us to produce a lot of urine. I'll show you a graphic in a second. We'll review the method of concentrating urine and the role of ADH, and you can be keeping in mind what would happen if we blocked that process of ADH's action. But the first class or type of diuretic I'd like to talk about among three types of diuretics is called a loop diuretic. And to understand what a loop diuretic does, we should quickly review how the kidneys concentrate urine, something we looked at last time. And over here on the right side, we remember that the filtrate, as it rises up from the thick ascending limb of the loop of Henle into the distal tubule, is very dilute. And in the presence of ADH, the collecting ducts are permeable to water, and as that dilute filtrate, I should say, travels down through the collecting duct of the medulla of the kidney, we see this sort of maroon shading, which reminds us there's a lot of salt out there, 1,200 milliosmoles per liter salt out here at the deepest part of the medulla. As that dilute filtrate passes down into the medulla, the salty environment creates an osmotic gradient or concentration difference so that water is reabsorbed by osmosis, and the remaining filtrate that we actually pee out as urine is a very small volume of concentrated urine. It's in fact potentially, with a lot of ADH around, going to be the same concentration as the medullary interstitium, 1,200 milliosmoles per liter down here. One thing I would like to mention, we talked about these two extreme conditions in order to understand the way the kidneys can dilute the urine on the left in the absence of ADH, and how they can concentrate urine on the right here in the presence of ADH by controlling the permeability to water of the collecting ducts. Usually, things are somewhere in between. So we don't always operate at these extremes. There's some ADH present. Some aquaporins would be in the membranes of the collecting duct cells. Some water would be reabsorbed, exactly the right amount of water, ideally, to keep the blood pressure where we want it, the blood osmolarity where we want it, 300 milliosmoles per liter. Okay, so that's our normal process of concentrating urine in the presence of ADH. A loop diuretic works by slowing down or inhibiting those sodium pumps in the thick ascending limb of the loop of Henle. That's where all that salt came from that's accumulated in the interstitium of the medulla, and if we slow down those pumps, the salt's going to wash away to some extent, and I drew in some edits there in green. Instead of being 1,200 milliosmoles per liter in this hypothetical case, the medullary interstitium is only 600 milliosmoles per liter of salt, and so there's a less concentration difference between the dilute filtrate and the interstitial fluid, and so less water can be reabsorbed by osmosis in the presence of ADH. So we wash out some of that salt gradient using a loop diuretic. All right, osmotic diuretics are substances that are not normally present in the filtrate, and instead of affecting the permeability of any part of the nephron, it's their very presence in the filtrate that affects the amount of water that will be reabsorbed. We'll use as an example glucose in the urine, but there are actually medicines that are osmotic diuretics. So let's take a look at what osmotic diuretics do. I drew some blue dots to represent the presence of a solute in the filtrate that is not normally present. If it was glucose, it would have been absorbed in the proximal tubule. There would be no glucose coming down here into the loop of Henle. So we got some solute there that's not normally present, and it's not going to be reabsorbed. It's going to stay in the filtrate. And so here, instead of having a very dilute filtrate that's arriving in the distal tubule, there's a bunch of extra solute in there, and that solute's going to remain in the filtrate as it travels down into the medulla and the collecting duct, and it's going to just reduce that concentration difference between the filtrate and the medullary interstitium, so there's less of a gradient, less osmosis, less water reabsorbed. So that's what happens with diabetics that are not well managed. If there's a lot of glucose in the blood, there's going to be too much glucose in the filtrate. The proximal tubule can't capture it all. It exceeds the transport maximum, or TM, of glucose, and so glucose is now going to spill over into the descending limb of the loop of Henle. There's no further opportunity to reabsorb glucose. It has to happen in the proximal tubule. Stays in there all the way through the loop, the distal tubule, and into the collecting duct, and hangs onto water essentially, acts as an osmotic attractor, and we pee out a large volume of more dilute urine, hence the polyuria in diabetes. Finally, thiazide diuretics work in the distal tubule. We talked last time about primary active transporters in the distal tubule that allow us to reabsorb salt, and then water is reabsorbed by osmosis under the control of aldosterone. So thiazide diuretics go to that location in the distal tubule where aldosterone normally turns up those sodium-potassium pumps, or adds more sodium-potassium pumps in the tubule cells. We're going to inhibit some of those pumps and reabsorb less of that water and salt in the distal tubule. Therefore, we're going to pee out more water in the final analysis. Why would we want to get rid of water? What if we had hypertension? One way to manage hypertension is by getting rid of some fluid volume. Volume goes down in the blood, blood pressure goes down. What if someone had a lot of edema forming and we needed to get that under control? What if someone had left heart failure and we have pulmonary congestion, edema, water accumulating in the lungs? That could be the end for someone who's in a very perilous state. We may want to use a diuretic to get rid of some fluid volume, reduce the pressure in those blood vessels, and there will be less filtration, less edema formation, and we can get that under control, and they can transport oxygen once again. Anyway, we may examine the urine for various constituents as well as the blood to analyze aspects of kidney function or to discover the presence of various diseases. So there's a lot of clinical relevance to analyzing the urine, and we did this in lab. We used the clinic sticks to take a look at the composition of urine with regard to specific solutes that have clinical relevance to certain diseases. We said that if we found sugar in the urine as well as ketones, that would be a knockout that there is unmanaged diabetes mellitus. The glucose should have been entirely reabsorbed in the proximal tubule, and the presence of glucose in the urine indicates a high blood glucose level and therefore a high filtered glucose level, and the proximal tubules were overwhelmed and glucose wound up in the urine, glucosuria. So under those conditions, which cells can't take up glucose because there's no insulin or not a functioning insulin, the liver starts metabolizing a lot of fatty acids and produces ketones, which it then releases into the blood for a source of energy production for cells of the body. And so the presence of ketones in the urine is a sign that those ketones are in the blood and that the liver is in that starvation mode, or that diabetes mellitus mode, the so-called keto condition. And so ketones and sugar indicate diabetes or starvation in the case of just ketones. If there's leukocytes in the urine, that's a sign that there's an infection or inflammation happening somewhere downstream. And so the inflammatory signaling chemicals that are being produced cause white blood cells to squeeze out of the glomerular capillaries. Normally they stay in, obviously, and only filtration happens. Water and small solutes go into the capsule. If white blood cells start crossing over and going to fight the infection, that's a sign of a urinary tract infection. So leukocytes might be present, but in order to confirm that there's actually a significant number of leukocytes, we would also be looking for nitrites, and nitrites would be present if there were leukocytes present in significant numbers. Normally there wouldn't be any nitrites in the urine. And also blood or hemoglobin. If there's a lot of inflammation happening, those blood vessels of the glomerulus would be very, very leaky indeed, and there'd probably even be some blood escaping into the urine. And so those three things together are a knockout that there's diagnosis that there's a urinary tract infection. Bilirubin. Bilirubin is a metabolic byproduct of recycling red blood cells. The heme group within hemoglobin, the red pigmented heme heterocyclic rings are red, and when the macrophages gobble up the worn out red blood cells in the spleen and in the liver and start recycling things, they convert the heme over to bilirubin, and the bilirubin is released into the extracellular fluid and then into the blood, and the bilirubin is avidly taken up by the liver. So bilirubin is not normally found in the blood in appreciable amounts. It's taken up by the liver, and then it's a component of bile. The liver produces this greenish yellow substance called bile, which then travels into the intestine through the bile duct, and it ultimately ends up coloring the feces. If there's bilirubin in the blood, there's going to be bilirubin in the urine, and there shouldn't be. So it's a sign that the liver is not able to take up the bilirubin as per normal. Could be a sign of inflammation in the liver, hepatitis, more advanced liver disease, cirrhosis. So that's a sign that there's something wrong in that handling of the bilirubin. Urobilinogen is a metabolic product of bilirubin in the intestine. What happens is bilirubin is entering the intestines in the bile, converted by bacteria in the intestines to urobilinogen, and then some of that urobilinogen is reabsorbed in the intestine back into the blood and winds up in the urine. So if there's excess urobilinogen, there's possibly another sign of a disease in the system that's normally handling the production or the removal of bilirubin from the blood and its placement in the intestines and so forth. Now we move to another assessment tool called renal clearance, which is an extremely powerful and elegant way of assessing kidney health and kidney function. Many times when the kidney function is diminished or compromised, the filtration step is the problem. The renal corpuscle, the glomerulus, is not able to produce the filtrate as it normally does, and now we have a big problem because we need to form that filtrate in order to reabsorb just what we want and pee out the things we don't want. So, glomerular filtration rate is a key point for clinical evaluation, but it's not accessible directly. There's a method called renal clearance that we can use to figure out the glomerular filtration rate. So first of all, what is renal clearance? This is a little bit abstract, and so don't be afraid to spend a little time kind of going over and thinking about this part of the chapter. I'm going to tell you the definition of renal clearance first, and then we'll go and look at specific examples, and that'll help clarify it further, and we'll see how we can use renal clearance to figure out glomerular filtration rate. Okay, renal clearance is the volume of plasma cleared or eliminated of a particular solute or substance per minute as the blood flows through the kidneys. Blood enters the kidneys, goes into the corpuscle, into the glomerulus, back out, paratubular capillaries, and out. How much of that blood coming out of the kidneys has been stripped of a particular solute per minute? That's what renal clearance is. Let me explain what I mean by that. First step in forming urine is filtration. So water, a lot of water from the plasma, and solutes is going into the nephron, into the renal tubule. then we reabsorb all of that water, right? We said that approximately 99% of the water is reabsorbed. And if that's all that happened, if all of the solute of a particular substance that we might be interested in analyzing were to be peed out and only the water was reabsorbed, all of the filtered volume is being reabsorbed. The clearance, the number of mils of plasma, pure water that's now present that was containing that solute, is the same as the number of mils filtered. In other words, if we filter 100 mils in a minute, we reabsorb those 100 mils, and all the solute is gone, then our renal clearance is equal to the same amount as the filtered amount. We filtered 100 mils, we've cleared 100 mils. So when you have a solute that's not reabsorbed, but yet it is filtered, the renal clearance is equal to the glomerular filtration rate. Now, in order to understand the power of that, it's just like, so what? Now we have another thing we don't know what it is. Well, it turns out that renal clearance is very easy to evaluate clinically, to calculate. So renal clearance is an expression of the function of the kidneys for any particular solute. You can never just say renal clearance by itself. Renal clearance of a particular solute. It only makes sense in the context of some solute that you name, and that's why I put little subscripts on these variables down here, because a lot of times people just write RC equals UV over P, but that has no meaning. You need to state the solute that you're talking about in order for it to have any meaning. So that's why those little S's are there. It just means any substance you may be analyzing. Okay, so renal clearance of a solute can be calculated as the concentration of that solute in the urine, easy to measure, the concentration of that solute in the plasma, we'll try to pick something that's easy to measure, and the urine flow rate. We have our patient in the hospital bed, we can collect all their urine and see how many mils per minute of urine they're making. So all we need to do is ask the clinical labs to measure a substance in the urine and in the plasma, and boom, we have the renal clearance. So it's pretty easy to find out the renal clearance of a substance as long as there's a clinical test for it, a chemical test for it. So here's what we're going to do. We want to find out what GFR is. We want to analyze the clearance of something that's not reabsorbed. So we inject inulin into the patient. It's a plant sugar or polysaccharide. So it's foreign to the body. There are no transporters in the nephron for inulin whatsoever. Doesn't even know what it is. So we inject this substance into the blood. It's filtered in the glomerulus. All of the water is reabsorbed. The inulin goes right out in the pee, and that absorbed water, that renal clearance of inulin, tells us what the GFR is. So all we need to do is inject the inulin. We have a patient lying there. They probably have a line in already, a venous line. We just inject some inulin, send away some blood and urine to the lab, keep an eye on their urine flow rate, and we now know the glomerular filtration rate. Pretty magical and very powerful tool for assessing renal function. Again, normal textbook GFR is 125 mils per minute. We hope that's what we're going to find when we do our inulin clearance. Even more commonly used is the clearance of creatinine to determine GFR, because creatinine, you don't even need to inject anything. Creatinine is a metabolite of creatine from muscles. And so there's always creatinine being gotten rid of in the blood, creatinine therefore in the urine, and we can use that to calculate GFR because creatinine is not reabsorbed. So again, if we know the plasma concentration of creatinine, the urine concentration of creatinine, and the clinical labs always check that when they do a panel of analysis of blood. They'll throw that in there and we'll send them a urine sample. Boom, we can measure GFR. There is a correction factor when you're using creatinine because about 10% of creatinine is secreted into the filtrate as the blood passes through the urine, so we need to make a little correction, but we can find the GFR very easily, and now we can find out if the kidneys are doing okay or not. We'll mention something about that in just a second, but this slide is kind of more for fun and maybe to illustrate a little bit more about what renal clearance is, clarify what it is. The main thing to know, though, is that renal clearance of a substance that's filtered but not reabsorbed is equal to glomerular filtration rate. What if you're an organic chemist, a medicinal chemist, interested in how the body, the kidneys, handle a particular new drug you're designing? If you gave the drug to the patient, and you found that the renal clearance was greater than the GFR that you measured by, say, creatinine levels, you'd know that the substance is being secreted. That wouldn't be so good. That means your new drug is being secreted into the urine and gotten rid of from the body very effectively, and that means you're going to be spending a lot of money on drug needlessly. So if renal clearance is greater than GFR, a substance is being secreted. If the renal clearance of a substance, particular substance, is less than GFR, then it must be being reabsorbed. And in the extreme case, renal clearance, of course, equals GFR. One more interesting special case, what if we filter some volume and solutes, we reabsorb all of that filtered water as usual, but we reabsorb all of a particular solute at the same time. How many mils of plasma are going to be stripped of that solute? 0. All of the water is going back, being reabsorbed, all of the solutes being reabsorbed, renal clearance is 0. And that's the case for a substance like glucose, which we normally reabsorb all of in the proximal tubule, just if that helps clarify what in the world renal clearance is. And then we have our case that we already talked about here in blue, in which we're talking about a substance not reabsorbed or secreted, and so that renal clearance equals glomerular filtration rate. So if the kidneys are struggling, probably the GFR is going down. If the GFR is going down beyond 60 mils per minute of fluid being filtered, that's called renal disease. Chronic renal disease, if it happens for 3 months, chronic just means long lasting. We have something to worry about. It's probably been going down slowly over time, and now we're getting into a clinically important situation of our patient. If the renal function gets so bad that the GFR is less than 15 mils per minute, that's essentially completely non-functional. The kidneys are not doing their job, and the person's going to become uremic. Uremia is a condition in which there's too much urea in the blood. Urea is just a product of protein metabolism, amino acid metabolism. If we want to burn up some excess amino acids, we'll tear off the amine group, combine it with a couple of carbon dioxides, and produce urea, and that'll be excreted in the urine. So if that builds up in the blood, it's toxic. And so we have to have constant kidney function to get rid of that urea. There are obviously a lot of other things that the kidneys have to manage, so uremia is sometimes used as more of a broad term to mean all the things that are going to be going wrong when the kidneys aren't able to filter enough water and therefore solute and to do their job. So it's not compatible with life. If someone who has renal failure and it's persistent, sometimes when people have renal failure, they have a severe trauma or surgery or a bacterial infection. They may even be septic for a period of time. They may have renal failure, but they may recover. The kidneys may rebound after the appropriate medical treatments and so forth, and they go through some healing processes. But sometimes there's not going to be a rebound. We have renal failure that needs to be treated in another way, and we'll have to replace that kidney function with either hemodialysis or kidney transplants. Hemodialysis is a pretty rough business, and when I first learned about hemodialysis and kidney transplant, it just sounded like such a perfect solution to a very dire situation. Wow, got that taken care of, knocked it out, patient's off the list, and we can go on with our lives. It's not quite that simple. People that go on dialysis don't usually do all that well. Usually about an average 5-year life expectancy when someone has to go on hemodialysis, meaning they're going to either pump their blood out into a dialysis machine to let the waste products diffuse out of the blood into a big salt solution in the machine and then back into the body, or we're going to inject a whole bunch of saline solution into the peritoneum, and interestingly, the plasma will exchange with all that fluid in the peritoneum, and the waste products will diffuse out into that fluid, and we can suck it back out and just keep on doing that back and forth, add some volume into the peritoneum, let it sit for a few hours, take it back out. We can do some hemodialysis. Not so good in terms of longevity. Kidney transplants, sometimes people that get a kidney transplant, it'll last for 20 years. But the average life expectancy of a kidney once it's transplanted in the recipient is around 10 to 12 years. So if someone is fairly young and robust, maybe they're only 55 years old, they're just hitting their stride at 55. Come on. So if they receive a kidney transplant, they need a kidney transplant, it's not going to carry them to their normal lifespan. They're going to need another kidney transplant at some point, presumably, and that gets complicated because of all the surgeries and so forth. Okay. Next time we'll talk more about the composition of urine, but particularly we'll start talking about the rest of the anatomy of the urinary system. We'll talk about the ureters, the bladder, and the urethra. So we'll talk about transport, storage, and release of urine from the body, and potentially some infections that may occur in that part of the system. So be watching for that. One more video to bring us to the end of chapter 25, and then I'll try to come back and produce some videos for the earlier parts of the chapter, which we haven't seen yet. So be watching for those. All right, thank you.